the integumentary system, hair. What do we have hair for? Well, we used to have enough hair that it helped to provide warmth for us. And when we contracted the piloerector muscle and it pulled on the hair shaft and our hair stood on end, then we created a boundary layer of warm air against our skin, and that kept us warmer. We can do that on our head now, but the rest of our body, we really can't do that anymore. So we've sort of lost that function. However, all the hairs on our body, if a parasite, if a little flea or a little gnat lands on one of our hairs, we're aware of that. So, come on, quiet back there. I'm trying to give a lecture. And I don't have patience for that. That is so rude. Okay. Parasites. Crawling on our skin, we can identify that. Okay, so scalp, heat retention. You can go outside if you want to talk, that's fine. Protection for sunburn. Beard, when males hit puberty, they get a beard. All of us get pubic hair, gets coarser. Our axillary hair gets thicker. Females, after menopause, you have a shift in your estrogen to testosterone ratio, and you start to develop hair on your face. So it's really a ratio of the sexual hormones that determine whether the male is going to have hair on his face from puberty, has higher testosterone to estrogen. Females, we don't have hair on our face because we have a higher estrogen to testosterone ratio. But after menopause, that estrogen level starts to come down. So relative to the testosterone that's already and still there, it gets less, and so the hair starts to appear on the face. Guard hairs, we have guard hairs that are eyelashes. We have guard hairs in our ears. You look at Guinness Book of World Records and a guy who can actually braid the guard hairs from his ears. I think he's from India or Pakistan or someplace like that. The hairs are so long that he actually has them braided, and he's made the Guinness Book of World Records because of that. We also have guard hairs in our nose that are going to help prevent parasites from getting up our nose. And we then have it on our inner ear canals, and also in our eyelashes serve that purpose. We use the hairs on our face for nonverbal communication. We use our eyebrows, we can bring them together to show a look of consternation. We raise our eyebrows to show that we're surprised, etc. So a summary of the glands that are associated with the skin. We have exocrine glands. The skin is at the surface of our body, so the glands are going to secrete onto the surface of our body. That is, by definition, an exocrine gland. So the secretions coming out to the surface of the body, if they're from the sebaceous gland or a sebaceous follicle, then if you remember back, they are holocrine secretions. The whole cell is your secretion. Sebaceous glands are associated with hair follicles. Sebaceous follicles, don't get it confused. A sebaceous follicle is a group of sebaceous glands that are secreting into one duct that will go out to the surface of the body. So a sebaceous follicle is not associated with a hair follicle, but a sebaceous gland is. This oily, lipidy secretion is to coat the hairs, to keep them more pliable, and to keep them from breaking off as easily. Some antibacterial secretions as well. This is more or less to protect the sebaceous gland from bacteria getting into the sebaceous gland and then causing inflammation there. So when you have severe acne, it's because parasites, bacteria and viruses have gotten into your sebaceous gland and caused an inflammatory process, hence the redness of the acne. When sebaceous follicles, they're usually located on the back between your shoulders. When those get infected, then you get really big, nasty looking acne. Sweat glands, they're mostly there to help cool our bodies. There's merocrine secretion, so they put the fluid into a vesicle, which then fuses with the apical plasma membrane and then exocytoses the fluid. They help to keep the epidermal surface clean. There is antibacterial secretions there from your merocrine secretions. Primarily you use the sweat to help you to have a little stickier surface for grip. And so you'll find, as we saw before, the sweat glands actually having their ducts coming out where your fingerprints are, the epidermal ridges. So that helps with gripping, it helps with thermoregulation. Water has a very high specific heat. That means you have to apply a lot of heat before it vaporizes. So in the meantime, it can absorb a lot of heat, move it out to the surface of the body, and then it can evaporate into the cooler air, and that will then cool our body. So we can conduct heat to the sweat, bring it out to the surface of the body, and allow it to evaporate. So we have conductive and evaporative heat loss. And as the warm air rises, cool air replaces it, and now we've got a convective heat loss as well. Apocrine sweat glands are, to remind you, merocrine secreting glands. They have a higher oil content. They have more components to them, so they have a little more funky smell. You find those appearing at puberty in the areas of the nipples, your axillary, and then your groin areas. So hormones will influence the secretions, and they're broken down into ceruminous glands, which we find in our external ear canal. They create a waxy secretion that will mix with the sebaceous secretions from the hairs that are in our external ear canal, and that's what makes our ear wax. The ear wax, you clean in there with a Q-tip, which you really should not do. You should only clean the outside area of your ear with a Q-tip. But if you get some of that earwax, you see that it's kind of a brownish orange. If you smell it, it's got kind of an acrid smell, kind of an acidy smell. And in the olden days, they actually tasted it, and it had a bitter taste to it. The smell and the taste apparently aren't very appealing to you. I see your faces going, ew. But also it's not appealing to parasites. So if you leave the earwax in there, the parasites don't go in your ear. The more you clean your ear canal, the more likely bugs are gonna go in there. And there have been cases where they found homeless people with big bugs, almost cockroach-sized bugs inside their ears. So leave your ear canals alone. They're designed to clean themselves so that the wax moves from inside to outside. You can clean where you can reach your finger with your Q-tips, but don't stick your Q-tip any further in. The apocrine sweat gland will actually develop into a true apocrine secreting gland in the form of a mammary gland. And those secretions will contain the apical part of the plasma membrane. So the top part of the cell will actually slough off and become part of the secretion. Along with the milk, then you get a lot of the cytoplasm, some protein, and a lot of fat from the plasma membrane. Alopecia is a term for thinning of the hair. Males get alopecia, females get alopecia. Males can progress to getting male pattern baldness. Alopecia is where you have fewer hairs per cross-sectional area. So you start to have your terminal hairs turn into the little vellus hairs, and so the space between the terminal hairs gets larger. That's referred to as alopecia. Stress can cause it. During pregnancy, the stresses, hormones that are fluctuating during pregnancy will cause the alopecia, and that then goes away when you have delivered the baby. You get your full head of hair back. Cancer treatments, medications can cause alopecia. Certain diseases cause alopecia. Hirsutism is kind of 180 degrees opposite. You're excessively hairy. You see people whose guys' beards go up to almost to their eyeballs, and goes down their neck and down their chest and out their arms. It's just like one continuous beard all over their body. That's referred to as hirsutism. They even have hair on their butt, and back of their knees, in their elbows. There's hair everywhere. It's usually a hormonal abnormality. Sometimes it's a genetic predisposition to that. Excessive, D meaning loss of squamous cells. Excessive desquamation is where you are getting dandruff or skin is coming off in excessive amounts. Dust mites are there because dust mites like to eat your desquamated cells. They like the protein and the fat content of the dead cells. So when you're dusting and you come to a glassy surface and you see a lot of white dust there, most of that is not dust at all. It's your skin that has sloughed off. And it's in the air, it's in your carpet, it's on other surfaces too, but it shows up the best on glass surfaces, shiny surfaces. And then if you see something that's kind of white but a little green and it's walking toward one of these stationary white things, that's more likely a dust mite. So you squish it. Better to just vacuum everywhere, wash everything, and then the dust mites tend to go away. But they like the desquamated cells. Burns, we'll talk a little bit more about that, and skin cancers, we'll talk a little bit more about that. Burns can be chemical, they can be thermal, and you damage either epidermis or parts of the dermis, or you can go all the way through the dermis. And cancers are due to change in the function of usually the epidermal cells, as we're going to be talking about skin cancers. You've heard of malignant melanomas, you've probably heard of squamous cell carcinomas, basal cell carcinomas. All of those are types of skin cancer. So skin cancer accelerated due to UV radiation, so exposure to the sun. So basal cell carcinoma is where the stratum germinativum, the deeper layer, is now undergoing mitotic rate at a faster than normal rate, and that will then change the surface of the skin. It will start to thicken, maybe look kind of scaly, appearance kind of grayish because there's more cells and less blood showing through. If any cancer breaks out of its site of origin into the dermis, it will have access to the lymphatic blood vessels, or sorry, the lymphatic vessels. Once the cancer cells get into the lymph system, they can go throughout the body really quickly. So although basal cell carcinoma usually isn't lethal, if it breaks through the basal lamina and gets into the lymph, it can be lethal. Squamous cell carcinoma is kind of a misnomer because the only squamous cells are the dead cells on the surface. These are actually the stratum spinosum, so the layers right above the stratum germinal. These are becoming cancerous. They often will break through the basal lamina faster than basal cell carcinoma. They tend to metastasize more so than the basal cells. They also tend to cause a lot of bleeding. So the patches of skin cancer may look similar to the basal cell carcinoma because they're kind of grayish and thickened areas, but they tend to cause more bleeding and just spontaneous bleeding. Somebody's just sitting there talking and chewing, and all of a sudden their face starts to bleed. They metastasize and get into the lymphatic vessels, get into the lymph nodes, and then can be lethal. The most deadly is malignant melanomas. Those cells are right next to the basal lamina. They tend to break through the basal lamina very quickly and also metastasize very quickly. So best to know your ABCDs of mole inspection. You want to look for asymmetry, which is the A, and then the border irregularities. So if it was round and now it's getting kind of jagged at the edge, or one side of it is growing out and it's becoming irregular in shape, that's a warning sign. Color changes, so if you can see a mole, check it out, know what color it is now, and if it starts to change color, if it was black and now it's turning red, if it was kind of brown and now it's turning black, if it's changing color, you get to the dermatologist. And then of course if the diameter gets over 6 millimeters, and 6 millimeters is pretty darn big, then you want to get to a dermatologist. So asymmetry, border changes, color changes, diameter changes, you need to go and get that mole removed. The development of melanomas is linked to an oncogene, which is a cancer gene called BRAF in men. That same gene in women is linked to breast cancer. So same gene, but different kinds of cancer, ovarian and breast cancer in females. For melanomas and mole inspection, all you can see is what's on the front of your body, what you can see in a mirror, and maybe what you can see by turning your back to a mirror. So inspecting the back area, you have to have somebody who will do it for you. Best to go to a dermatologist and have them check out the moles. If you have moles on the front of your body, you've got moles on the back of your body, go get them checked out. So UVA, UVB, and sunscreens. I have been a swimmer since age 7. I taught swimming. I was a lifeguard. I taught exercise out in the sun. I had a lot of sun exposure. And when I started, we had nothing that was a sunscreen. We had baby oil, which made us look better after coming out of the sun. So it seemed to make the skin a little bit more moist. They had copper tone, which was just an oil. They had no sunscreens, probably until about the early 70s, so before you were born. The first things that came out were things like zinc oxide and titanium oxide. If you have ever put that on your skin and gotten exposed to the sun, you'll never do it again. Did that once with zinc oxide, and layers of skin came off my nose. And I didn't know what was going on, but I was never going to use that again. I mean, the sunburn was not as bad as the zinc oxide. Then they came up with titanium oxide. I've never tried it. Anything with oxide, they're trying to stay away from that. Then they came up with PABA, para-aminobenzoic acid. And this was like the holy grail of sunscreen. It was supposed to protect you from everything. And then it turns out that all three of these damage the DNA in your skin and actually make the epidermis thin faster and make you more susceptible to skin cancers. So as far as I'm concerned, I trust no sunscreen anymore. The only sunscreen that is good is a hat and a shirt and shade. And that's the only sunscreen that I will ever trust in my life again. So there are tanning rays and burning rays, and while the new sunscreens say they will protect you from the UVA, which is the tanning ray, and UVB, which is the burning ray, you still tan. So if you are tanning, they are allowing rays to come through and stimulate your melanocytes. I asked my dermatologist once about this. How come you still tan if it's supposed to be blocking UVA? He goes, oh, no worries. I said, well, that's not an answer. So in other words, you don't know, and he did some other things I didn't care for, so I don't see him anymore. Okay, so any exposure to tanning, any exposure to burning, if you read the peer-reviewed journals, they will tell you that more than likely you are going to, with that exposure, initiate skin cancers. Burns, you probably all burned yourself, hot surface. Mommy says stove is hot, but you gotta prove it to yourself, so you touch it, and then you find out, yeah, mommy's right, that doesn't feel so good. Hot water, the exposure to hot water. With the hot surface, you don't feel the hot, you feel the pain. And that's why you pull your hand away so fast. Water, hot water, you might get the pain reaction, but more than likely, it's not hot enough to initiate a pain response. And so it's going to take you a couple of seconds to figure out that water's hot. You get into the shower, you get into the bath, and 1 or 2 seconds later, oh my gosh, it's hot, and you pull yourself out or you jump out of the tub. So hot is traveling in an unmyelinated nerve. It takes a while to get to your brain and realize that that is hot water or hot surface. So you have time with that exposure for actual burn to occur. Sunlight can cause burns, radiation causes very bad burns, electrical shock, really bad burns because you burn from the inside out, and then acids and bases can also cause burns. Most people die from burns because they dehydrate, and that's why they die, or they get an infection and the infection kills them. First degree burns, you see red is just the surface epidermis that has been damaged. The damaged epidermis sometimes will block a sweat gland, so if after you're feeling better you start to exercise and then the sweat is released underneath the damaged epidermis, a blister may form. But it's not a blister due to the burn, it's due to sweat accumulating, fluids accumulating underneath the damaged epidermis. So they're red and painful, you have a swelling that irritates the nerves, that's why it's painful, but usually not blistering. True blistering is due to damage of the epidermis and then fluids collecting under the epidermis and raising the epidermis up. So since you have actually detached the epidermis from the underlying dermis, you've got to heal that epidermis again. When you do that, then the blister will pop on its own. If you burn yourself and blister and you think, ooh, that doesn't look good, and you pop it, then you're just giving route for bacteria to enter and get into the dermis. So you don't want to be popping blisters. The epidermis will regenerate from intact sweat glands and also intact hair shafts. So if they're still there and the epidermis around is still intact, you get a very fast healing, and it usually is scar-less type of healing. Third-degree burns, you have burned all the way through the dermis, so you've lost your sweat glands, you've lost your hair shaft, and you've lost the epidermis in that area. So you've got to, depending on how big the damaged area is, you've got to wait for stem cells to migrate in, and that's going to take a while. So usually they'll speed it up by grafting skin onto that area. If you have intact skin that they can harvest, and then in the olden days they used to just cut little slits in about a 2x2 piece of skin and then stretch it so that you're applying the stem cells to a larger surface area. That sped up the healing process. Now they can take those stem cells and culture them in the lab and then bring your own skin back to you. And they also have a technique that sort of looks like saran wrap. They put that over the burn and it seals it and promotes somehow, I'm not really sure how, the regeneration of the skin underneath. And then as the skin is growing in, the saran wrap, the plastic will just kind of peel off, and then they just trim it until everything is healed. And usually with in the periphery, you get good healing. You may not need as much skin grafting. So there have been a lot of advancements from when I used to work in a burn unit. Disfigurement with third-degree burns is very common because you lost all the surface tissue. So even with skin grafts, the skin isn't going to be the same as it was prior to the burn. And depending on what surface of the body is burned, if you've got a facial burn, you might have lost your nose, you might have lost part of your ears, and then you have to go to reconstructive surgery. You have to get a good plastic surgeon to try and build your features back. Treatment, IV. You die from dehydration. You have to get the fluids into your bloodstream on a regular basis. And you have to apply something to the surface that will act like an epidermis so that you don't lose the fluids by just evaporation. So IV nutrition, sometimes they're burned so badly that they can't eat, because if they're burned in the facial region, they can't chew, they can't swallow efficiently. So replace the fluids and also monitor the electrolytes. There was a guy who got burned when they were building the Alaska pipeline, and he was shipped down to the hospital that I was working at on the mainland. And he came in, he was badly burned, but maybe 60%, 50-60% of his body. But it was an oil burn, so it was a nasty third-degree burn. He was doing really well for about a week and a half, and then one day he woke up and he was having hallucinations. He was fighting off things. You weren't even in the room, and he was telling, don't touch, don't touch. And he just really was out of it. And they didn't really know what was going on, but a medical student who had patients went through the chart, looked at all the lab results, and figured out, oh, these electrolytes are imbalanced. So they replaced the electrolytes, and the next day he wakes up and he's back to normal. And he said, oh, it was kind of strange yesterday, huh? And I said, yeah, you were very strange yesterday. And he said, what was that? He said, oh, your electrolytes were off. My what was off? And he said, yeah, all the minerals in your bloodstream. Oh, okay. So just don't let that happen again. Because he knew he was acting strange, but as far as his brain was concerned, it was real stuff going on. Debridement, don't call it debridement. You go and you listen, or you go and you look in the dictionary. It's debridement. My mom used to always say debridement. But you don't argue with your mother, because you get in trouble when you argue with your mother. So I just go, oh, that's debridement. And she keeps saying it. Okay, so debridement means you go in and you take away the debris. That's what you're talking about, dead cells. So burn dead cells, you got to go in there and scrape off the dead stuff. So it's not a pretty thing to do, and I don't know how the patients put up with it. First patient I ever worked with was burned 80% on her body. It was all front burn, this height, and he just barely had enough that she could sort of lay down comfortably. She had the greatest attitude. She just said, I know I'm not going to get better until you get rid of all this dead stuff, so just go for it. And I'm not going to cry, I won't scream, I won't do anything, just do it. And she was good to her word. She never cried, she never whimpered, she never complained. And she healed really fast. Of course, you got to control for infection, so there's salves that you put on that will also help with control of fluid loss, but also prevent infections. 3rd-degree burns, and there's also 4th-degree burns. That's all the way through the muscle to the bone. But 3rd-degree burns, you can do skin grafts. You can, if you have skin that's intact and you can harvest it, grow it in the lab and bring it back to the patient, or do the little magic with the little slits and then spread it out over a wider surface. They are your cells, so they adhere and replace your cells. You won't reject your own skin. Isograph, how many in here have an identical twin? Okay, Tuesday, Thursday, there's one guy with an identical twin. So he could get skin from his identical twin. It's not going to be identical to his skin, but it's going to be the closest thing to his skin. So less of a rejection if you have an identical twin. So everybody in the room is out of luck, because we have no identical twins. So we could take tissue from our body if we have enough. If you have only 20% of intact skin, you're not going to be going to the intact skin very often for autograft. Culture keratinocytes wasn't available way back in those years, but it's available now. Homograft, also called an allograft, you're getting another human to donate skin. Back in the 70s, what they used were xenografts. So they get pig skin. They get skin from other animals and apply that. It's not so bad because it will cover the surface, prevent infection, and also give you less dehydration of forming. But you're going to reject it because it's not of the same species. Amnion, for a while they were using amniotic tissues, but then politics got in the way, and I don't know if they're still using that. I think now they're relying more on the culture, skin culture. This artificial silicone and collagen, that's the stuff that they apply, and then it covers the surface, and you slowly get healing underneath, and then you just trim away the stuff that is then peeling off because the skin is healed underneath. Okay, sebaceous glands, talked about them, oily, waxy. So this is just a summary of all the glands that are in your body. Sebaceous glands have a hair associated with them. Sebaceous follicles, no hair, but a lot of sebum. Glands of Zeiss, you look at your eyelashes. There are little glands that are secreting into the shafts for those eyelashes. They're called the glands of Zeiss. They're actually sebaceous glands. And then you have meibomian or tarsal glands. If you look at the flat part of your eyelid, go close to the mirror, take off your glasses, look at the flat part of your eyelid. You're going to see tiny little holes in that flat plate. That's called your tarsal plate. If you pull your eyelid down and look at the inside of the eyelid, you're going to see these red, kind of wavy red streaks coming up from the base of the eyelid up towards the top of the eyelid. Those are your meibomian glands, also called tarsal glands. They secrete a very lipid-rich substance that then gets onto the surface of your eye, mixes with the water from your lacrimal glands that are up here in the top of your orbit, and that prevents the fluids in your eye from dehydrating, from evaporating very quickly, and then helps to clean the surface of the eye, and then everything drains down into your nose and moistens your nasal cavity. If those glands get stuck up with makeup, there was just a couple years ago, I think there was a makeup trend where they actually painted the tarsal plate with their eyeshadow. Well, the rate of styes went up like huge through the roof, and so they stopped doing that. But people who wear eye makeup, you have to be careful to keep that tarsal plate clean. And if you get an infection in the meibomian gland or tarsal gland, it's called a stye. I think the posting, I didn't have the E for you, but it's S-T-Y-E. S-T-Y is like pig sty, so not the same. This word, chalazion, I think this might be pronounced as an E, chalazion, but you can pronounce it however you want or just say sty. It's the same thing. So there are a lot of things that you can do to help prevent this. Just apply a lot of moisture, make sure you keep your face clean, and then you usually won't have styes. Top or bottom, you can get the infection stye. So sebaceous follicle, a lot of sebaceous glands, no hair associated with it, common duct to the surface of the body. Sebaceous gland associated with a hair shaft, and thyroid muscle, when that contracts and pulls the hair into a vertical position, then the sebaceous gland is squished and the secretions come out into the hair shaft. And these are the artist illustration and then a light micrograph of sebaceous and a hairless hair shaft. So apocrine, merocrine, true apocrine secreting glands are the mammary glands. The rest of these sweat glands are actually merocrine secreting glands. So one is called a merocrine. The other one, which secretes in a merocrine fashion, is still called an apocrine sweat gland. It's an old nomenclature. They haven't gotten rid of it yet. The apocrine are the ones that appear around puberty. They're associated with the axilla, the nipples, the groin regions. They have a more odorous secretion, and so the old guys thought that because it was more fatty, that it was part of the cell was there in the secretion. So struminous glands only found in the ear canal. They're modified sweat glands. They produce a waxy secretion that mixes with the sebum that's associated with the hairs in your ears to form your earwax. Fingernails. Skin is keratinized, hair is keratinized. Fingernails are even more keratinized. You scratch your skin, doesn't feel too bad, but it's irritating. You scratch your hair, well, you're not going to feel anything because all of that is dead, but you can, the true hair down below is still alive. It's associated with the nerves associated with the hair shaft. That's why it hurts when you pull on it. This is even further keratinized. It's so keratinized that now the proteins are translucent. And the pink that you see, and if you press on the finger pad, it's supposed to get bright red there. And that is your ability to see the blood through these translucent fingernails. If you come proximally to where your cuticle is, in anatomical terms, it's called eponychium. This white area called the lunula, you only have partially keratinized cells there. Where it's fully keratinized, you can put a lot of pressure and you don't really feel any discomfort. You feel the pressure, but you're not pulling away from that. Just with light pressure in the area of the lunula, it's already uncomfortable. So keratinization will make a very tough, resilient, protective structure called the fingernail. Fingernails grow out but remain attached to the underlying tissue by a hyponychium. And eponychium is your cuticle. Don't mess with your cuticles and don't mess with your hyponychium. Cuticles, you go for a manicure, they might want to push those back, but if you push them back, then you're exposing the root of the nail to bacterial, fungal, and viral infection. If you get an infection at the root of the nail, the whole nail may stop growing. Or it may stop growing temporarily and then slowly grow out again, or it may stop permanently and you lose the fingernail. You've ever temporarily lost a fingernail or a toenail, you know how sensitive that finger or toe is while that nail is growing back. So they're really there for a lot of protection. The lateral nail folds, they're usually, we don't spend a lot of time drying in that area. When we dry our hands, the eponychium may get dry, hyponychium may stay moist. These crevices on the sides also stay moist, and they can be then good breeding grounds for bacteria, viruses, and also for funguses. You're out in the garden and rooting around with bare hands, you need to come in and scrub those really good and make sure that they're dry. If fungus gets under the lateral edges of the nail will come away from the nail bed laterally. If the fungus gets under the nail at the root, then the whole nail may stop growing. Fingernails grow about 1 millimeter a week. If you keep your fingernails short, you know how fast they grow. If you have them long, then you kind of ignore it until it's time to trim them. But if they're short, then you know that they will grow at different rates. So if you're physically active, they grow faster than if you're a couch potato. So if you're going in and out of physical activity, active periods, and then periods where you're sitting around studying, you know your fingernails will grow slower when you're less active. Toenails, they grow really, really slow. So if you're trimming your fingernails to keep them short 2-3 times a week, you're probably trimming your toenails probably once a month, maybe once every 2 months. They're that much slower in their growth rate. When you go in for a physical, when you are doing a physical, if you go in with your fingernails painted, the doctor's going to grab his little nail polish remover, and he's going to take all the fingernail polish off, or he's going to hand you the bottle or the pad and say, remove that stuff. Why? Because that is the inspection of the fingernail can be diagnostic of a lot of problems internally in the body. So brittle nails breaking a lot, you can see that even with fingernail polish on. But it's a sign of anorexia or bulimia. So eating disorders will show up in the fingernails. Person may be denying any eating disorders, but you look at their fingernails and you see that they're breaking off and splitting and things like that, then you know probably that person is not being truthful. Fingernails, you look at your fingernails are supposed to curve up. They're not supposed to curve down. If the fingernails are curved like the bowl of a spoon, that is referred to as spooning of the fingernails. This is a sign of iron deficiency. Along with the spooning, you press behind on the pad of the finger and the fingernail is whiter or opaque, then it's also a sign of iron deficiency. So hypochromic, meaning less red, iron deficiency. Yellow fingernail syndrome, you're going to see this with the elderly. So a lot of times nail polish is applied to cover up the yellow fingernails. The yellow fingernails usually are thicker, and you can't cover that with fingernail polish. They're also going to change in the convexity, so they actually become more convex, and the fingernails may be, some of them may be missing. You'll see that the skin is painted instead of the fingernail, just because the lady wants everything to match. So that's to cover up the fact that they've lost the fingernail. This is a sign of lymphedema, so fluids collecting due to blockage of the lymph vessels. Chronic bronchitis can lead to this, so lung problems. The bronchiectasis is where the walls have broken down and you've got floppy airways that trap air inside the lungs. Inflammation of the bronchioles and other lung diseases, obstructive lung diseases. So bronchitis, bronchiectasis, inflammation in the lungs, these all lead to a decrease in oxygenation. Clubbing, if you've worked with people who have cystic fibrosis, it's very apparent when you look at the fingers that something is different. So normal fingernails kind of go out like this, and theirs will go like that. So it's like somebody took the tip of their finger and just smashed it down, and it's permanently in that shape. So they refer to that as clubbing of the fingernails. So chronic lung cancers, but also cystic fibrosis will give that appearance. If you've ever smashed your finger in the door or hit yourself with a hammer, you know that you've probably seen little white streaks or white splotches in your fingernails a couple weeks to months later. And you think back, if you know what it is and you think back, you know when you whacked yourself or caught your finger in the door. So deformation of the nail bed will cause these white streaks. If the whole nail is getting more opaque, then that's probably a sign of anemia. Teres nails, the whole nail becomes white and it looks opaque. So you press behind and no pink shows up, or there's only pink really far out on the fingernail. That's a sign of liver disease. So usually alcoholic cirrhosis or some other kind of cirrhosis causing liver disease. So that's why the physician will take nail polish off to look at the fingernail. So nervous system and endocrine system will control your skin. Mechanical stresses, wearing shoes that are too tight or rubbing will cause calluses on your feet. Walking around barefoot, running barefoot will cause calluses on the soles of your feet, calluses on the heels, calluses on your toes, usually due to malfitting shoes. Calluses on your hand, if you do manual labor, you'll get calluses on your hands. I used to play monkey bars in 3rd and 4th grade, and I guess I remember those calluses developing at that time. I guess just enough manual labor is done that the calluses have never really gone away. They've gotten smaller and less thick, but they're still there. Skin will usually regenerate as long as you can get granulation of stem cells to replace the lost tissue. If you don't get the cells replaced, then other cells will take over that space. And usually that will be scar tissue, because fibroblasts are everywhere. And so if your dermis and your epidermis aren't replaced, then fibrous tissue will fill in that space. Old lady here, you look closely, her hair is thinner than it should be. That's alopecia. The white color, she's lost the melanin production in the hair, and now the medulla is full of hair, and so the hair appears white. She's got more wrinkles. The wrinkles are due to loss of subcutaneous fat, also loss of the elastic fibers that are produced by the fibroblasts. She's got bags under her eyes. Maybe she had them, some people have them all their life, but this gets more pronounced as you get older. The skin will have some blotches of brown and then depigmentation in other areas, and those are the liver spots that appear with age. They're not really liver, but they have the color of liver, so that's why they got called liver. The older people tend to apply a lot of moisturizers because the epidermis gets dry. Why? Because sweat glands atrophy. The hair gets thin because there are fewer follicles producing terminal hairs. More of them are just producing the vellus hairs. The drier skin, and then that cracks more easily and may bleed more easily. The vitamin D production goes down. As you get older, your skin tolerates UV exposure even less. So not going out into the sun, you may be deficient in vitamin D. So as you get older, you have to find a source of vitamin D in your food. So some orange juices, milks, and then breads will be fortified with vitamin D for that reason. The Langerhans cells, which are your dendritic cells that are part of the immune surveillance, they get fewer in numbers. So with the thin epidermis drying and cracking, that leaves a pathway for bacteria and other parasites to get in. With less of the Langerhans cells to fight them off, then they get into the underlying tissue. Because sweat glands are atrophying, they have problems with thermal regulation. If you're going to be teaching older people exercise, you must remember this, because you can overheat them very quickly. They cannot tolerate 40 minutes of exercise on land. They will overheat, and they may be dropping out of your exercise class, and maybe they're too polite to tell you that they can't tolerate it. Sometimes they do, and better if they exercise in the water, because you can lose the heat to the water very quickly. And but they have less subcutaneous fat, so they may not tolerate cold water. So you go to city and county pools. How many city and county pools are heated? They're heated to take the chill off, and then they're turned off. So you gotta find a pool that is heated. The older people at the Y, they would prefer the YWCA's pool water to be at, I think around 92, 94. Try swim in water that's 92 and 94. You come out cherry red, you look like you have just been exposed to cyanide or CO or something. And the swimmers can't stand that. And I fully empathize with them. You don't want to be swimming in water that's that hot. But the older folks, they can't be in there for 40 minutes without getting cold. So you got to strike a deal and find them wearing their little wetsuits. Okay, so everything thins, less blood supply, the less fat. So then more saggy skin. You have less subcutaneous fat, doesn't support the skin as well, and everything is kind of droopy. With less blood supply, everything is healing more slowly. The slower you heal, the more likely that the fibroblasts will take over the production of cells and fibers, and you'll end up with a lot of scarring in the area. Okay, melanocytes get fewer, sun tolerance goes down. Fewer active sweat follicles, thermoregulation is impaired. Change in distribution of fat and hair, skin sags, get thinning up here, so now you're more susceptible to UV radiation. Blood supply goes down, leads to lack of everything above, also causes the epidermis to get drier. Drier because there's less sweat follicles. Thinner epidermis because lack of blood supply. And UV radiation, if you're out there tanning now, at your age, you're going to have thinner and more damaged epidermis when you get to be my age. Okay, take a break and we'll start on bone.